Our senses are the entrance to the oasis known as the world. The sensation is the only factor in understanding the environment, situations, and scenarios. The senses of smell alerts us to the scent of the flower. The sense of touch alerts us to the physical characteristics. And the sense of tastes, wait, we don't taste flowers, do we? When a needle pricks the finger, these sensations immediately trigger the ouch and we move the hand away because these reflexes travel along certain pathways and pass through the brain. These reactions are necessary for human existence and even if painful, are necessary to understand the dangers around. But what if we wanted to temporarily stop these sensations and as a result our ability to understand pain? What can be done to prevent this pain? Is providing a pain-free experience to the patient even humanly possible? Therefore, sensing your interest in these queries, we invite you to join us on this adventure as we discuss the miracle of dentistry, the inferior alveolar nerve block. The first and foremost thing to do when you have to give local anesthesia to a patient is to talk to them before getting started with the injection technique, since this will make them feel less anxious. This can be done by addressing the patient with their name and explaining to them what they should expect, and assure that after the prick, they won't feel any pain during the whole surgery. Additionally, asking the patient to take a deep breath also helps to calm them down a bit. Local anesthesia can be given using various techniques such as nerve blocks, infiltration, and field block. Nerve block involve the main nerve trunk where a local anesthetic agent is usually deposited so that different types of pain can be prevented or managed by anesthetizing a large area. Whereas in a field block, local anesthetic is deposited in a relatively small area by injecting a wall of anesthetic solution across the path of the nerves supplying the operative field. Local infiltration or supraperiosteal is a type of injection that anesthetizes a smaller area, usually 1 or 2 teeth and their associated areas. Anesthesia is usually deposited at nerve terminals. In this video, we'll be covering the anatomy of inferior alveolar nerve and the general features and various techniques of the inferior alveolar nerve block. The maxillary and mandibular divisions of the trigeminal nerve supply the oral cavity. The inferior alveolar nerve is a branch of the mandibular division which is divided into 4 other branches. The nerve is housed in the mandibular canal and supplies the mandibular teeth via the dental plexus, which are seen as multiple tiny branches emerging towards the roots, providing pulpal sensations. The terminal branches are the incisive and the mental nerve. Inferior alveolar nerve block, also known as mandibular nerve block, is the second most frequently used nerve block technique in dentistry. The nerves that are anesthetized during this block are inferior alveolar nerve, lingual nerve, mental nerve, and incisive nerve. The areas that are anesthetized by this block include the mandibular teeth, buccal mucoperiosteum, mucous membrane anterior to the mental foramen, and lower lip, which are supplied by the mental nerve, also get anesthetized by this block. Apart from these, anterior 2/3 of the tongue and floor of the oral cavity, lingual soft tissues, and periosteum supplied by the lingual nerve are also anesthetized. Hence, this nerve block can be used for quadrant dentistry. This means that it is indicated when procedures are to be carried out on multiple mandibular teeth in one quadrant. Based on the areas it acts on, it is also indicated when buccal and lingual soft tissue anesthesia is necessary. Now, as we have seen when it is necessary to give this block, it is also important to know when it is not supposed to be given. Long-acting bupivacaine is contraindicated in a very young child or a physically or mentally handicapped adult or child, as these patients are more likely to bite their lip or tongue after the areas are anesthetized due to a feeling of numbness. In patients with hemophilia, infiltration is preferred over nerve block to prevent excessive bleeding. A sharp needle would easily pierce through the soft tissue with minimal discomfort. With the use of disposable syringes, this problem is rarely encountered. Another important aspect while using the syringe is the direction of the bevel. When the bevel is directed away from the bone, the needle tears the periosteum, leading to pain and barb formation, which will lead to pain while withdrawing the needle. Hence, the bevel must be directed towards bone such that the needle slides over the periosteum. This decreases the chance of periosteum tear. It is vital to know that we are pricking the needle in the correct area to avoid block failures. Certain anatomical landmarks act as guides which are palpated prior to the needle insertion. These can be divided into soft tissue and hard tissue landmarks. Soft tissue landmarks include the mucobuccal fold in the region of mandibular premolars and molars, retromolar triangle area, pterygomandibular raphe, and pterygomandibular space. Hard tissue landmarks include external oblique ridge, internal oblique ridge, anterior border of ramus, coronoid process, coronoid notch, and occlusal plane of mandibular molars. The traditionally used inferior alveolar nerve block technique is called the Halstead technique, named after the surgeon William Stewart Halstead. The direct inferior alveolar nerve block technique involves the insertion of a needle into the pterygomandibular space by piercing the buccinator muscle. Once in the pterygomandibular space, the aim of the technique is to deposit local anesthetic solution at a level just superior to the tip of the lingula, and therefore, knowing the boundaries of the pterygomandibular space is necessary for this technique. It is anteriorly bounded by pterygomandibular raphe, posteriorly by parotid gland, laterally by ascending ramus of the mandible, medially by medial pterygoid muscle, superiorly by the two heads of the lateral pterygoid muscle, and inferiorly by attachment of medial pterygoid. The content of the pterygomandibular space is the inferior alveolar nerve and the lingual nerve. An important identification point while giving the block is the pterygomandibular raphe, which is a fibrous seam that descends from the pterygoid hamulus of the medial pterygoid plate that separates to give rise to the superior constrictor and buccinator. When locating the landmarks in this technique, the patient must be in a supine position with mouth wide open for visibility and accessibility, and the occlusal plane of the mandibular teeth must be parallel to the floor. In case of a right-sided block, the operator will stand at 8 o'clock position facing the patient. For a left-sided block, the operator will stand at 10 o'clock position by the side or slightly behind the patient. 3 parameters must be considered during the administration of an inferior alveolar nerve block. 1. The height of the injection. 2. The anterior-posterior placement of the needle, which helps to locate a precise needle entry point. And 3. The depth of penetration, which determines the location of the inferior alveolar nerve. In order to determine the appropriate height of injection, one must ask the patient to keep their mouth open as wide as possible and then place the index finger or the thumb on the anterior border of the ramus of the mandible and move it up and down until the greatest depth is felt. This is called the coronoid notch. The significance of the coronoid notch is that it's on the same level as that of the mandibular foramen. After this, extend an imaginary horizontal line posteriorly from the fingertip in the coronoid notch to the deepest part of the pterygomandibular raphe, determining the height of the injection. This imaginary line should be parallel to and 6 to 10 mm above the occlusal plane of mandibular molars. The finger on the coronoid notch pulls the tissue laterally, stretching them over the injection site, making them taut and enabling needle insertion to be less traumatic while providing better visibility. When the tissue is stretched and is held taut, the needle passes through easily, leading to less needle tip to tissue contact and leading to less discomfort. Whereas, when the tissue is not stretched, the needle tip to tissue contact is prolonged, which leads to a longer duration of discomfort. Next, let us discuss about the anterior-posterior placement of the needle. The anterior-posterior site of the injection is determined by 2 points. Point 1 falls along the horizontal line from the coronoid notch to the deepest part of the pterygomandibular raphe. Point 2 is on a vertical line through point 1, about 3/4 of the distance from the anterior border of the ramus. Hence, needle penetration must occur at the intersection of these 2 points. In the third parameter of the inferior alveolar nerve block, which is penetration depth, bone should be contacted. Needle should be advanced slowly until bone contact is felt. The depth of penetration is 20 to 25 mm or 2/3 to 3/4 the length of a long needle until bone resistance or contact is felt. Keep in mind to not force the needle into the bone as it can damage the bevel of the needle. A small portion of the needle usually remains outside the tissue, which is necessary because if the patient makes any sudden movements, the needle can break at the junction of the hub, which is easy to remove, as opposed to the entire needle being pierced inside or a very minimal portion being inserted. Oftentimes, less than half the length of the needle in an adult passes through, which usually means that bone is contacted too soon and that the needle tip is located too far anteriorly on the ramus and there is a failure of anesthesia. To correct this, the needle must slightly be redirected such that the syringe barrel is placed more towards the front of the mouth over the canine or lateral incisor on the contralateral side until a more appropriate depth of insertion is obtained, ensuring that the needle tip is now located more posteriorly in the mandibular sulcus. If the needle does not contact the bone, it means that the needle tip is located too far posterior or the body of the syringe is too anterior at the level of the first premolar. This might lead to post-injection trismus as the needle will pierce the medial pterygoid muscle and there will also be a failure of anesthesia. To correct this, the needle should be withdrawn slightly in tissue, leaving approximately 1/4 of its length in tissue, and the syringe barrel should be repositioned more posteriorly over the mandibular molars. If the bone is not hit at all, there is a possibility of damaging the facial nerve, which will result in facial nerve paralysis. One should also keep in mind that multiple attempts of giving the block will result in pinpoint injuries which causes trismus. A 2 ml syringe should be held with a pen grasp, approaching from the contralateral premolar and advancing at the area of insertion. The next step is to insert the needle and when it contacts the bone at appropriate depth, withdraw it by 1 mm to avoid subperiosteal injection. After this, aspirate in 2 planes to prevent accidental intravascular deposition, which if not done can potentially generate undesirable complications and slow down the rate of anesthetic solution deposited. Beginners should give multiple aspirations as they do not have a very steady hand and can result in positive aspirations. This can be assessed by checking the color of the blood. If a vein is punctured, the color will be dark brown. If an artery is punctured, the color will be bright red. If positive aspiration is achieved, the syringe should be discarded and a new local anesthetic syringe must be used to aspirate again. Using the old syringe will not tell us if negative aspiration is achieved due to presence of blood in the syringe and blood is acidic in nature. Therefore, local anesthesia will not act as it works in alkaline conditions. Another important point to know is that the solution must be deposited slowly. Otherwise, there will be a rapid distension of tissues which ultimately will cause pain. On achieving negative aspiration, 1 ml of solution is slowly deposited first in the inferior alveolar nerve, followed by 0.7 ml in the lingual nerve and 0.3 ml in the long buccal nerve over a minimum of 60 seconds. Have you ever wondered why the inferior alveolar nerve is anesthetized first? Well, it is because the inferior alveolar nerve is a deep-seated one and therefore a sterile needle must be first pierced into this, followed by a more superficially placed lingual nerve and buccal nerve. The syringe is then slowly withdrawn and the needle is recapped. After approximately 20 seconds, seat the patient in a semi-upright position and wait 3 to 5 minutes before testing for pulpal anesthesia. Now that the block has been given, we need to check if it's actually working. This is done by assessing the subjective and objective symptoms. Subjective symptoms are those which the patient can feel. It usually exists as a feeling of numbness, especially in the lower lip and tongue. Objective symptoms are assessed by the operator using a blunt instrument such as a periosteal elevator and propped on the gingiva in the mental nerve region where the patient will respond with no pain. Now let's have a look at a few complications encountered with this block. The most common one is hematoma formation. This happens when the needle of the syringe accidentally nicks an artery or vein instead of anesthetizing the nerve, leading to the effusion of blood into the extravascular spaces. It usually occurs immediately and stays for 7 to 14 days. The second most common complication associated with this block is trismus of the jaw, which occurs due to multiple attempts at giving a successful block. The third complication seen is transient facial nerve paralysis, which is due to the block being given too far posterior and the needle contacting the capsule of the parotid gland where the facial nerve is located. Signs that should be looked out are inability to close the eye on the affected side, drooping of the corner of the mouth on the affected side, and asymmetrical smile. When such a situation takes place in a dental setting, reassure the patient that it is only temporary. Remove any contact lenses that the patient may be wearing and place an eye patch on the affected side or manually close the lower eyelid periodically to keep the cornea lubricated. Wait for the effect of local anesthesia to wear off to assess if the paralysis is temporary. Even though this block is the most frequently used nerve block technique in dentistry, it is entitled to the highest number of failures due to its steep learning curve. Presence of anatomical discrepancies such as bifid inferior alveolar nerve foramen, accessory nerve innervation, descent of the mandibular foramen in children, flaring of the mandibular angle, and the inconspicuousness of the pterygomandibular raphe in elderly individuals result in greater chances of block inaccuracies. Thus, a supervised practice in a simulation model can aid in gaining an extra edge of manual dexterity before clinical practice to master this block and render it successful. We hope this video gave you a deeper understanding of the topic. You can access notes and multiple choice questions on this topic on our website and mobile app. Don't forget to like, share and subscribe to the channel. See you all in the next one.